I'm Dr. Sean Coomer, transplant surgeon and chief medical officer at the University of Kansas Health System. Welcome back to Open Mics. The president announced using acetaminophen, commonly known by its brand name Tylenol, during pregnancy could contribute to autism risk. To discuss, let's go to today's morning rounds. Please welcome Dr. Mark Parrish, Director of Maternal Fetal Medicine Program. Dr. Parrish, what are you telling patients about Tylenol?
We are continuing to tell them the same thing that we've been telling them for years, that Tylenol is the safest and most effective pain reliever as well as fever reducer that you can take in pregnancy. There's other options that you can take as a non-pregnant adult that we know are safe, but many of those things have been proven to have adverse consequences to the pregnancy. Acetaminophen continues to be tried and true, safe option for these patients.
So can you discuss the risk of patients not taking medicine and just dealing with pain and fever? We know there's a risk there too.
Absolutely. I'd say the biggest concern is for those patients that do have a fever. We know that while pregnant, if you have a fever, that can start to impact the development of your child, especially first trimester, early second trimester. And there are some other impacts on DNA synthesis that are occurring throughout the entirety of the pregnancy that can be disrupted if a mom has a fever. So for sure, we don't want moms to have sustained fevers, and we want them taking Tylenol. We also know, Dr. Coomer, that patients that are in extreme pain constantly, that causes a lot of internal stressors in the system that can raise inflammatory processes that can also have negative consequences to the pregnancy. And so, for sure, we're talking about the consequences of just letting extreme pain go, letting fevers go, versus taking a safe agent. We're going to recommend taking that acetaminophen, which is safe in pregnancy every time.
On the bottles, over-the-counter bottles, it has recommended dosages, it has maxes. What do you tell patients about the medicine and dosage?
Just in general with any of the medications, including with acetaminophen, we're going to tell them, we want you to take the lowest effective dose for the shortest duration of time. And if you're having to take it consistently more than 24, 48 hours, then we want you coming to us and having a conversation, either calling us or making an appointment immediately to come in and see us.
Okay. So autism remains a mystery for many scientists, doctors, and families. What do we do now?
It is a lot of the studies that have brought up these concerns that have been raised in the public eye have been based on science that is difficult to say is well-founded. So a lot of the research that is being reported is retrospective in nature, so they're going back in time and they're relying on recall from patients. Did you take Tylenol or acetaminophen? They're relying on recall from their providers. Did your patient take these medications? And then they're trying to put this into a statistical model that is saying, is there a potential association with Tylenol and these neurodevelopmental outcomes that we're seeing in children, specifically autism being at the top of the list of things that have been discussed recently. And we can say that obviously those research efforts are, while necessary, can be fraught with a lot of error, a lot of bias. And so it's really difficult for us to say that you can take home anything of significance from this data right now. So I would just caution people that are out there to, anything that you are hearing in the media or reading, certainly that can spur some good conversations with your physician and bring up some good questions. Take those concerns to your physician and have a serious conversation with them. Maybe Tylenol or acetaminophen is not the right thing for you. But in most cases, we're going to say that it is very safe, and we're going to recommend continuing to take it.
Okay. Well, Dr. Parrish, thank you so much for being here. I really appreciate your insights, and thank you. I'm sure you've been out there doing a lot of talking right now. So thank you so much for your service to the community and our patients.
Thanks.
Thank you. Now to today's main topic. The next time you're in a doctor's office, you might notice a little more eye contact. physicians at the health system have started using an AI note-taking tool that can capture and document conversations between patient and provider. It's meant to give doctors more time to focus on you, the patient, instead of data entry. We're explaining that and other AI tools with the folks joining me today. Dr. Keith Sale is a head and neck surgeon, ENT surgeon, as well as the Chief Medical Information Officer and Vice President of Ambulatory Services for the health system. There's a title.
Right? Too long.
Dr. Denton Shanks is a family medicine provider and the health system medical director of AI, informatics, and digital health. And Chris Harper is the health system's chief information officer who also co-chairs the health system's AI, or artificial intelligence, steering committee. Really glad you're all here. Thanks for being here. So, Dr. Sale, you recently sat down with our producer, Stuart Downing-Vest, to show him what this AI note-taking tool can do. It's called a bridge. Let's take a look.
One of the challenges in healthcare today is documentation, right? So how we capture our interaction with you as a patient and put it into the medical records that we have a log of what happened, right? Doing that with an electronic medical record means a lot of us spend time in the system while we're talking with our patients, and that takes away from our attention, our time with our patients. A bridge is a great way to get around that and allow something else to do some of that work for us so that we're just doing more editing than we are doing all the actual data entry piece of it.
Yeah, I mean, you're sitting here looking at me like you would, but you've got this computer on your side. I would prefer you talking to me
Right.
as opposed to talking or typing in the computer. We recently saw one of your colleagues, Dr. Denton Shanks, in clinic using a bridge, and we saw him basically press record on his phone right as he entered into the clinic visit. But outside of that, it didn't look or feel much different from a normal clinic visit. So for a patient, what difference is there going to be?
Hopefully there's a big difference in the attention your physician pays to you, right? I think one of the biggest things I've noticed since using this tool over the last year is that I spend most of my visit face-to-face with my patients, which is fantastic. And very little time in the EMR, all the time demonstrating or showing them something that's a test result or an image or something like that.
A few minutes ago, we started a little demonstration where I was describing some actual jaw pain that I felt in the past, just like I would if I was sitting down in a first clinic visit with you. And a bridge was listening the whole time. Let's go ahead and see what a bridge heard and how it gets entered into the chart. So sure. What did it see?
Right. So first it pulls in our conversation. You can see right jaw pain, different joint symptoms. It bullets or highlights the symptoms that you had that went along with that. And just as an example for our conversation, you said it was 1 or 2 weeks long, particularly with palpation. It's significant enough to cause wincing, especially when you're accelerating or stopping your car, right? So it captured a lot of the key episodes. It also talks about your history, right? You grind your teeth at night, you have a mouth mold, but maybe don't wear it as often as you should, right? So it captured all of that symptom, and including the negatives, where you don't have any issues really with your ears, other than some ringing in the ears, but that's not really directly tied to this.
I see a brief outline kind of what I talked about, some bullet points there, a paragraph under the assessment and plan. How does that compare to what you would be able to write?
So the more I've used it and the more I correct things or change things, the more it becomes like what I would like to use from my notes. Ultimately, I still have to go through and edit this much like I would if it were a transcriptionist or a scribe in the room or something like that. The documentation is still mine. I have to validate what was recorded and put in there, but ultimately it's very close to what I would need, and so I don't need to spend a ton of time editing and reviewing it, which is really nice.
Doc, thank you so much for letting us into your clinic today.
My pleasure.
Well, that was pretty interesting. So, 2 big benefits to discuss with the bridge. Starting with the provider. Can you explain for the audience just how time-consuming clinical documentation can be and how a tool like a bridge can help with that?
Sure. You think about the average amount of time a physician spends doing documentation. It ranges anywhere from 18 to 40 minutes per patient. And it depends on the complexity of that patient, whether it's a new patient, established patient, it can vary. But as the number of patients you see throughout the course of the day increases, the challenges with documentation increase. And so if you're seeing, I'll see 20 to 30 patients in a day, depending on the mix, and the amount of time that I have to spend doing data entry, typing notes, prior to a bridge or prior to any kind of a tool was dramatic and significant, right? It'd be hours after clinic finishing this documentation. Now I can walk out of the room and the documentation is there. It's a detailed summary of the patient conversation and of my components of that conversation when I talk through the assessment and plan, the physical exam. All of those pieces are there. I run through and I verify what the patient said, what the exam components were, maybe add a few things, and then I could actually sign off that note within a few minutes of leaving the room with that patient.
Okay. Dr. Shanks, anything to add to that?
Yeah, I mean, on a full day at clinic previously, I would finish work, go home, see family, see kids, and then start charting at about 11 p.m. And would chart until 1 a.m. and maybe get done, maybe still have a few more to do. And again, that is several hours after clinic, and so I hope I don't forget anything. And now with this AI tool, I walk out of clinic often a few minutes early with my notes done, and I have already verified them. I already checked that they're high quality notes, and I'm done and out.
Yeah.
I can spend the evening with family and get to bed at a reasonable time.
A little more balance in life, that's
Yeah.
for sure. I think you referred to it really, and we talked about it, is pajama time as physicians. The time we spend outside of our daily work, and what do? We should be getting ready for bed or spending some time with family. Have you noticed less pajama time for yourself and among colleagues?
Yeah, I think Denton could probably speak. We've done some studies on this across our organization. Personally, I used to do a lot of direct entry notes in the clinic, so talking with patients directly and having a conversation while I'm typing, and then trying to answer questions, ask questions, et cetera, going back and forth. So I was pretty quick at getting through my day, but even then would have an hour or two of stuff to finish at the end of the day. I don't think I realized how stressful that was until I started using a bridge and a documentation tool like it, where now I actually feel like I can engage my patients more effectively. I have more time to spend with them face to face, and I'm not stressed about finishing the documentation. And nor am I worried about spending 3 hours at home while I should be spending time with my family trying to get through that documentation. I can finish within an hour or so at the most after clinic.
Yeah. And I think you alluded to it. So what the benefit for the patient, right? So what are other benefits for the patient?
Yeah, I think it's classic now. If you ask a patient what your doctor looks like during the exam room, most would say that they're over here typing on a computer while the patient is standing on the other side trying to get the doctor's attention. And now I really have no fear of not facing the computer, giving my full attention to the patient, and knowing that AI is going to ambiently record this conversation, document it well, and I can give my full attention to the patient. Yeah.
Great. So with these new healthcare technologies, there may be concerns about information accuracy and privacy, especially when it's transcribing audio. So Chris Harper is going to join us. Chris, what level of trust do you have in a bridge and that'll be able to interpret medical language or understand someone's accent, for instance?
Yeah, with the advent of what I think you hear commonly as a large language model or generative AI, it is truly a learning technology that the more you interact with it, it learns different either accents or different way of speaking. And so, one thing that we see all the time with a technology like a bridge is that it gets better. And really, we've been using it at certain specialty, and as it interacts with other physicians, other specialty, it even gets better at learning and understanding our language, our accents, and so forth. And so, one of the things that people always ask me is, so, with ChatGPT coming out almost 3 years ago now, what's changed? Because these technologies have been around for a while. Well, the difference is the computer can speak human language and understand human language so much easier. And that's where we saw the value of a tool like a bridge. And we wanted to make sure that our providers had access to a technology like this, so then we can take care of patients better.
So I assume this is a little bit of the natural language processing. And how do you ensure that a tool like a bridge can abide by all the relevant laws around privacy and data sharing?
Yeah, and so we go through a pretty rigorous security review of any technology that we introduce to our organization. And so, we are very confident with the ability of Bridge to keep our patient records and data safe. Won't get into a whole lot of details, but really, a lot of the data resides within the device itself, and it has the ability to remove that data autonomously. And so the goal is to make sure that all of the technology we use at the health system, especially patient-facing, goes through a pretty rigorous process in ensuring that the data and the technology is safe for use.
Right. Thanks, Chris. We are here to answer your questions. Please send them in using the links on your screen, YouTube, Facebook, or email the Medical News Network. So it's not just physicians using these AI tools, right, Dr. Shanks? How is AI helping your clinic nurses?
Yeah, we have a few Epic tools right now that our clinic and family medicine are specifically piloting. One of them, when patients write in messages, the AI helps them draft a response. It is not an auto reply. You're not getting an auto reply right back from the AI agent, but you're getting a drafted response that the nurse can then take a look at, can personalize, can add some things to, and then move on and send a high quality, empathetic, caring note back to the patient. And so that's one tool. Epic has a whole suite of other AI tools that are being integrated. One that really helps me also is chart summarization. When I see a patient in clinic, I would love to instantly know their entire medical background, but that is a lot of clicks, a lot of documents to look for, and so if I can use AI to smartly, intelligently summarize some of their past medical history, it gives me a leg up when I walk in to see them to remember, oh yeah, we did talk about that at the last appointment. And you saw our ENT friends for a specialty visit earlier this year, and it summarizes it together and gives me the important facts.
Now, I'm glad you brought that up, because this is not just about doing notes and letting us sleep a little bit more and have more wellness.
Yeah.
This is about giving better care, right? Summarizing someone's care is pretty important before you meet them. So it's also hard to stay up to date with medical research. New studies are being published every day. You can read constantly and never catch up. Some physicians are using an AI tool called Open Evidence. Dr. Shanks, how is that used?
Yeah, open evidence, in many ways, I think of it as when I'm in my clinical space seeing patients, I would love to always have a colleague sitting right next to me that I could bounce ideas off of, get some quick questions, give more confidence in the treatments that I'm giving. And now with this AI tool, I can really use it as a chat tool and ask it actual clinical medical questions and get back very evidence-based with citations discussion. And it's not just one question, it's not like Google searching, it's actually a back and forth conversation with memory that I can use over time. I wanna make sure that with these tools, it's easy to go to a conference and find a new tool to use, but we need all of our tools to go through our health system cybersecurity team, make sure that they're well validated, make sure that they are quality, because we're dealing with patient information here. So very important to partner with our IT team on these tools.
Yeah. So AI is changing how we work. So big picture, it could put some people out of work. How do you see healthcare jobs adapting to these new tools?
It's a great question, and one we get frequently. I would tell you there's no secret that there is a physician and healthcare provider shortage nationwide. This is an opportunity for us to extend our ability to take care of patients in a high quality and safe manner by providing us information that we sometimes would take days, weeks, even months to be able to collate together. You mentioned all the studies that are out there. Medical information doubles about every 3 months. That's a lot of data that's out there to try and go through and summarize and figure out what the next best steps are. Artificial intelligence and tools like a Bridge or similar, like you've seen in Epic, allow us to consolidate that information quickly and efficiently so we can help patients make decisions about their own personal health care in a safe and effective manner. I think the goal is not to replace people, it's to enhance our ability to take care of more people and to do it again safer if we can.
Yeah. I think that's a pretty sobering fact. You mentioned the doubling of medical information that fast. We've all been in practice for quite some time, so it's tough to keep up, right? I mean, these tools are definitely helpful. So we know many of you have questions. Let's head to Studio B with Alexis Del Cid.
Good morning. We have a good question from Jeremy. Jeremy wants to know, does the AI software just record, or does it think too? For example, does it look at your notes and highlight things where the AI thinks it got it wrong, or anything like that?
You want to?
And maybe I can help.
Yeah.
Oh, okay. I
Yeah.
Dr. Harper over there.
I appreciate the promotion, but no, I think these are technology that goes through a different phases of learning, and so probably the last step in what this question is referring to is large language models go through a process of pre-training the model, post-training, and reasoning. And so it goes through that reasoning layer enough that it can actually, in a computer speak, think about the best way to be able to highlight things and really be able to bring intelligence truly to these type of technologies. So the way I think about it is really a synthetic intelligence, right? Because we're using a silicon-based computational power to be able to come up with intelligence. And so I will say that there are some technically reasoning being applied to the data that's being entered into and retrieving, not just a simple memory of calling back data.
Yeah, I would add to that. It has that conversational component as it listens to me talk to a patient, and it can pull out the relevant things that are health related, but not necessarily talk about the conversation we had around the baseball game last night or the Chiefs' performance, when they lost the Chargers, right? All of those things are extraneous and not necessarily brought into the history of their present illness, nor to our conversation about the assessment plan. So there is that ability to comb through that conversation and bring forward the relevant parts of the conversation for providing care.
I think it's very important to understand what tool you're working with, what that tool is capable of doing, what it's not capable of doing. The Abridge tool that we use to document is not there to make diagnoses. It's not there to interpret the results. It's trained to understand what is important medical knowledge and to make sure that that gets into the note. There are other tools that are trained to make diagnoses or trained to be able to give you the next best step in medical care, and that's how those are trained. And still with all of that, we need to understand what data went into it, what biases the AI has. Humans are biased, AI is biased, and we just need to understand more. A lot of education, a lot of training goes into how to use these tools.
Marie has a question. Marie wants to know, what if I want to say something confidential that is health related, but don't want it in my notes? Will Abridge record that?
This is a great question. It will record the entire conversation, and as we mentioned earlier, this is still the physician's content that goes into that note. And so this is a way no different than having a scribe in the room who might transcribe that piece of the conversation, but as the physician, if I know you don't want that in the note or want it particularly in a private way, we can still go through and edit that note and remove those pieces. So it's a first step towards documentation, but it doesn't complete the documentation or the visit, and we have the complete ability to edit and move things in or out of that note.
The recording is permanently deleted afterwards, and so what is the true medical information is the doctor's signed note. And notes could be slightly wrong or misinterpreted, I mean, in general, even without these AI tools. So I think if, as the doctor's reading the notes, they need to make sure they edit it. If a patient ever takes a look at a note and says, that's not quite what I meant, they're more than welcome to write in, and we can adjust the note as needed. But this tool is very intelligent, helps save time, and is very useful for our clinical practice.
Yeah, and that's key, right? As you said, the physician has to edit that note, nurse has to edit that note, and should, because it's not always, it doesn't replace you. It just assists you.
I think it's very important that patients know that this is not an AI automated thing. This is just an assistant tool that's helping really physicians, nurses, other care providers be the best that they can and use their time efficiently and effectively.
Joan has a question, and Dr. Sale, you mentioned scribes. Joan wants to know, is it common to have a scribe in the doctor's office? Does the health system employ medical scribes?
It's another solid question. So I would tell you, documentation has been a burden for decades in healthcare. It hasn't gotten better, it's actually probably gotten worse. And so one of the ways to try and tackle that is by employing scribes. And we do have scribes in our organization. And so Abridge functions in a similar manner, not necessarily exactly the same. Abridge doesn't, or historically didn't have the ability to tee up orders, as an example. So as we go through a conversation, a scribe in the room can say, oh, you wanted a chest x-ray, you can put an order together so that I, as a physician, can then go in and identify that order, verify its accuracy, and sign it. Abridge now is developing that ability as well. And so it will become much more like a true person in the room. But right now, it's still in development for those types of functions. So there are some nuanced differences, but in terms of completing the actual note and the content within the note, it functions very much like a person in the room.
Alice has a question. She wants to know, as this continues to develop, are there any problems that you're still working on or any growing pains that you're seeing?
I'll let Denton start with that one because he's been on this process for a long time.
Okay, can you repeat it? Sorry.
Yeah, Alice wants to know if you've experienced any growing pains with this, or are there any kinks you're still working out?
Just things that we're still working out.
Growing pains and things of that nature.
I mean, it's a new technology. One, the company itself has been doing a phenomenal job of coming out with new features, taking providers' feedback and coming out with new features on a monthly basis now, really growing fast. And with each of those new tweaks to the application, it's a little bit of a learning curve on how to best use the tool. I adjust the way that I speak with patients some. I actually think it's for the better because I want to clarify things both for the patient and for the AI. If I want something that I think is very important to have in my note, I actually say it again, repeat it to the patient in very clear language so they understand, but it also helps me make sure that the AI understands. So these are all little kind of tweaks that we make over time to really best use the tool. We want the best AI-human partnership, and there is a learning curve to that.
I would add to that, we were one of our Bridge's first two partners, right? And so I give Dr. Shanks and Dr. Ader, my predecessor in this role, a ton of credit for being foresighted enough to think about this technology. We have a core of physician and medical professional leaders who test, develop, and try out these types of tools. We spent years piloting this type of a tool to make sure it was right before we were able to roll it out to the rest of the organization and physicians can use it on a wide scale. We've now achieved that and have almost 1,000 users now using a Bridge across the organization. But to your point, it is something that we take very seriously. We make sure we test very carefully because there's a lot of development that goes into these tools.
Yeah, I'm a very big supporter of AI tools, but I am also one of the biggest critics, and I want to test everything, I want to break everything, and really make sure that it works the way that fits into a clinician's workflow and that is really providing the best care for our patients.
And maybe one thing I would add to that. One thing I would add is, it's nothing different than our other technology. And so really, if you think about even on your iPhone, there are bugs that gets introduced and even though it seems amazing as these tools and how they function like a bridge, it's nothing more than just a technology, and it's really how we utilize it and improve it so that the tool gets better as we interact with them more. And so I think there's sometimes people understand that misnomer that these technologies are perfect, but they are not. And so that's why we always need to make sure that our physicians or users are in control.
Well, this has been a great discussion. I'm really grateful to all of our guests for being here. And I want to get final thoughts before we go. So, Chris, do you have any final thoughts?
Yeah, I think final thought is, I really see these technology now, in my mind, it's at a point where it can truly aid our physicians and patients, and in order for them to do their job better and be taken care of even safer. And so for me, the more of these capabilities are introduced, we will be doing our best to make sure it's safe, but also effective for our care that we deliver every day. So I am pretty excited about where we're at in the stages of our technology.
All right, thanks for being here. Dr. Shanks?
Yeah, I think these AI tools absolutely help all of our clinicians, help us provide better care, and really with the right governance and quality control, with the right people and financial support, we're able to do a lot more with our employees, but really exponentially more work. And so provide much better quality care to patients, and very excited to continue to work with these tools.
Okay. Yeah. Dr. Sale?
I would say the one thing we hear frequently in circles around artificial intelligence in healthcare is keeping the human in the loop. So as you've heard from both Chris and Dr. Shanks, this is a technology that assists us in taking better care of patients, potentially even more patients, safely and effectively. And so we need to continue to develop this tool just like we have other tools over the course of history, whether that is the stethoscope or the MRI machine or artificial intelligence. This is one more tool in our toolkit to help take great care of patients here at the University of Kansas Health System.
Right. Yeah, I think, the advancements in science and medicine are going at an exponential pace. And I think, ironically, when you think about AI is technology, but it allows us to personalize medical care again, and it keeps us away from dealing with all the technological advances. So I want to thank again all of our guests, and to our audience, remember, faith, hope, and science.
Imagine being told your pain is not real and that the condition you think you have doesn't exist. That's what happened to one woman. I'm Alexis Del Cid on the next All Things Heart, how she was finally diagnosed here at the health system and treated for the condition that is often overlooked and misdiagnosed in women. Thursday at 8 a.m.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.